A bit of background about me. So before I joined Islington Council, I worked in global health and studying evidence-informed decision-making processes based in an academic research center and a think tank. So I was very much on the side of kind of making recommendations to policymakers. So what I've tried to do today is incorporate some of my reflections of what I've learned over the last few years being based at the council, kind of on the other side, as it were. And before talking about ways in which research can influence policy and practice in local government, I wanted to situate this discussion within what could potentially be done. So we wanted to start with a quick Mentimeter brainstorm. I believe the link is in the chat. And if you could put in your thoughts on what local authorities do, what types of interventions would local authorities be likely to implement? And as people are adding, if you have any thoughts on kind of the services. That's great. I think that's a really good start, and I'm impressed. So broadly, what you've covered, I think, is a good reflection of what happens in local government. So the Local Government Association estimates that that local authorities provide over 800 different types of services. But as you can see from this figure, the majority is really spent on statutory responsibilities, predominantly adults and social care. And public health and housing are a much smaller share of this. I think smaller than at least lots of residents that we interact with think that it is. So the next slide shows that this pie is shrinking over time and has for the last 15 years or so, with increases in expenses outpacing revenues. And we're having to spend an increasing proportion of resources going to acute services. The next slide shows funding for local government and public health relative to NHS, just to put this in a broader context. So with these background context slides, how can research influence policy and practice? The next slide shows 4 domains that in a traditional policy matrix you would include when you're trying to compare different options. So a policy matrix would typically cover the effectiveness of different interventions, cost effectiveness, political and administrative feasibility, or automaticity, as it's sometimes called in the policy process literature. So the latter refers to the extent to which an intervention can be delivered through existing systems, or if you need to hire new staff, set up a new physical location, for example. And so my PhD is in public policy, and so we would have done a matrix like this, come up with like a fairly clean kind of ranking of and trade-offs of different policy options. And I would say being at local authority, these factors are indeed important. But I think one of the biggest things that's really been impressed upon me in the last few years is that in a context when need and demand exceed resources, there may be effective interventions, there can be political will, but when the number of cost-effective interventions often far exceeds what's financially feasible, many decisions are really about prioritization. So for example, research that provides more disaggregated findings about effectiveness across different population subgroups can be more useful than averages. So really asking about effectiveness for whom. And importantly, when calculating cost effectiveness, it's really important to be mindful of which institutions are bearing the costs and which institutions accrue the savings, because often they aren't the same. So our health determinants research collaboration is focused on wider determinant interventions. So things like housing improvements, which may be paid for by local authorities, but often the savings calculations are typically based on savings to the NHS and sometimes the criminal justice system, which doesn't necessarily mean that that money is available for local authorities to invest in the housing improvements. So broadly speaking, if you don't mind advancing one, which should, I think for us as researchers, and I still see myself with that hat on as well, I think in terms of producing relevant research, and if we're serious about influencing policy or practice, I think it's really important that we're clear about what specific decision-making processes we're trying to influence. So sometimes we'll see in recommendations very sweeping statements like policymakers should invest £1 million in X intervention. But these types of kind of recommendations or statements aren't often particularly actionable. If you'll go to the next slide. So in local authority, there are formal processes through which decisions are made, with phases prior to and following the decision where less formal interactions take place. And here, there are just 3 examples from a paper I'm working on with colleagues that really tries to characterize some of these processes, including the types of evidence that each requires, the people that are involved in different phases, and the timelines. So what are called key decisions? These are based on budget thresholds. So this would typically include things like new strategies, like a housing allocation policy, the introduction of the Livable Neighborhoods Initiative, and large procurement and contract awards for services that we externally commission. In the second column, there are annual scrutiny committee cycles where each committee would identify a topic to review each year. So recent examples of this are overcrowding and persistent absence. And then in the third column, the regulatory committee review process would consider applications for building, fast food takeaways, alcohol and gambling establishments, so entities that are sometimes the subject of public health interventions. And just to note that all of these meetings are open to the public who can come and ask questions and make comments, and the reports and reviews are all publicly available on Council's websites as well. So although I think sometimes they can be a bit difficult to find, a lot of this information is available. So understanding these specific decision-making processes, I think will really help to make research recommendations more actionable. So for example, key decision reports have a set template, and they're required to outline alternative options that were considered and financial, legal, equalities, and climate implications. So these types of evidence will always be useful. In terms of timelines, we sometimes work with MSc students who conduct evidence reviews. And in theory, this would be particularly helpful with scrutiny committee reviews. But unfortunately, the timing is somewhat perfectly misaligned with the scrutiny committee process, where topics are defined in the summer, evidence is presented in the autumn, and recommendations are developed by March. So MSc students who pick projects in late autumn start going through ethics review and work on them in the spring and summer with recommendations end of summer. That unfortunately doesn't fit the timeline where those reviews can be included in scrutiny committee processes. And then I also just wanted to mention that there are constraints on what is feasible. So certainly financial considerations, which I mentioned, but also in terms of regulatory committee reviews. So our planning decisions are guided by our local plan, which is informed by the National Planning Policy Framework, and the London Plan, which is the spatial development strategy for Greater London. So that looks at the London strategic land availability and housing market assessments. And things like, so both Tower Hamlets and Islington are the 2 most dense local authorities in the country. So in addition to kind of financial constraints on building more housing, there are basic things like just land availability and space. So just things to keep in mind in terms of when you're producing evidence, how it might feed into these processes and the types of evidence that might be more actionable than others. I just wanted to close on the next slide. So this just shares some of our general guidelines from the council in terms of if you're looking to collaborate with local authorities on research and evaluation. I would say we're very keen to do so. But I think in the past, researchers, and I include myself as one of them, have really relied on kind of the goodwill of people to participate in interviews and do data cleaning to share data. But I think moving forward, we're really trying to be as strategic as we can. And so these are just some examples. So we're more likely to be able to collaborate with external researchers when the research topic is aligned with our 2030 plan and strategic plans, that there's sufficient staff time to be involved. And I think local authorities across the country, in part driven by NIHR, are really trying to cost in that time just because cost constraints have been increasing over time, essentially. I think this third bullet is really important, that if the research is likely to yield actionable findings that can be done with existing resources, rather than the conclusion being, oh, we need X million additional pounds to do this. And then on the right-hand side, that just shows for Evidence Islington, our health determinants research collaboration. These are kind of the criteria that we use in terms of how we're internally identifying which thematic areas to invest more time in. And I guess I would just say, just to go back to the first slide that Allison mentioned when she was describing research impact, the last bullet point on that was talking about tangible benefits for society. And I would say at the council, that is very much how kind of our evidence and research approach is driven. It's really very much based on how will this reduce health inequalities and improve the health and well-being of residents.
Thank you very much, Anne. So we'll just pause now. So as things come to mind, if questions come to mind, do post them in the chat. Or just reflections even, doesn't have to be a question. Thank you, Anne. Chris, whenever you're ready, we'd like to invite you to share your presentation with us.
Thanks very much, Alison, and great to join this session, and really pleased to hear your work, and really nice to meet you. So my talk is really from the perspective of an applied health researcher, and as a GP. I spent, I don't know, probably more than 20 years as a GP in Hackney. And a lot of the things that I worked on really were just things that were responses to the difficulties that we saw, the challenges, that problems that the patients had. So it was, you know, kind of what came through the front door of the practice, which was many and varied. So my perspective is over research over more than 20 years really of time in northeast London. Yeah, so I guess the first question is why do you want to have impact, the research that you do? And I think we live in interesting times, as the Chinese proverb said, and here are just some of the things that might irritate you and frustrate you, and things that you might want to do some research to change. But I mean, the scope here is vast. But why can't we immunize ourselves against flu? We just had a pandemic. It seems ridiculous. Why is the health system gummed up at an A&E? These are kind of intractable problems. Why are there so much inequalities, particularly here on the right around lung disease in society? So there are lots of things, and you'll have the things that you're interested in yourself, but the scope for research is vast, and the need for impact is great. The next slide. So whose job is impact anyway? And maybe like me, your views may change over time, because when I was an ECR, we didn't call them ECRs then, but I just thought, well, it's my job to do the research and publish a paper, and that's someone else's responsibility to deal with it after that. So next slide. So not long, quite early in my time in research, I worked on a program that was trying to determine whether introducing asthma specialist nurses into a borough, in this case Tower Hamlets, would help to would reduce the number of people admitted to hospital, in this case unscheduled care, so emergency care for asthma. I mean, this is to my mind was a pretty important problem, because first of all, there's a lot of morbidity associated with asthma, and the people who end up in hospital have really significant disease, and it's hughtely disrupting for them. It's costly for the health service, it's costly for society. So reducing unscheduled care for asthma seemed like a really important goal. So we carried out a randomized trial in Tower Hamlets, and half the practices, we recruited all the practices in Tower Hamlets, and half the practices had the support of randomized to getting the support of a specialist nurse who went out into the practices and supported the practices and helped them manage the patients who had attended with unscheduled care, whether that was A&E attendance or hospitalisation or out of hours. And we gave it a nifty acronym. This was a trial of introducing asthma specialist nurses to reduce hospitalisation and acute care for asthma. So we published the paper in the BMJ, and I thought that was fantastic. What an important contribution. So next slide, please. And this was an outcome. So, it was a great paper, but no one took the blind bit of notice of the work that we'd done. As far as I could see, it didn't influence anything. And in fact, I know there's a big program of work trying to sort of replicate what we did 20 years ago. This was published in 2007. So it's not, okay, put it another way, impact is your job. You've done the research, you want that research to have impact. It's really down to you to plan and put in the time, the strategy, the planning to give your work the maximum impact. Obviously, a lot of time and effort and money goes into the research. If there's no impact, then arguably it's a waste of time. So you can choose here. When's the best time to start thinking about impact? Any of those, but clearly it really need to start right at the beginning when you're designing the study. This is critical, because if you're addressing a particular question, you need to think about the right design to answer that question. You've got to think about what policymakers want in terms of evidence, and so you need to be able to deliver the evidence using the right design to be persuasive when it to improve healthcare. So here's some of the things that I thought of regarding impact. So top of my list is you want to have the most influence in the work that you do. So think really about the big questions. So they will vary from area to area, but really try to think, well, what are the most important questions? What are the things that are going to make the most difference to the area that I'm particularly interested in? Think from the start how your results might influence policy, and as I've said just now, choose the right design. Think about how generalizable your results will be. So you need to build that into the design of your study to ensure that your research is not just relevant to the local community, but maybe London or the UK or beyond. What's the goal of your research? And always I found that working with the best researchers really just maximizes your chances of success. So, make collaborations with the best researchers in your field, because that will improve your chances of doing good research and ultimately having good impact. And think about context, because an intervention that works in one setting may work differently in another setting. So you need to think broadly about the research that you're planning and the effects that it might have. Next slide. Okay, so think who the stakeholders are. So is it who are you trying to influence here? Is it public health leads? Is it the public? Is it public advocacy groups? Because they can have a lot of influence. They can be very persuasive. They're active on social media. So if you're influencing those public advocacy groups, then you can change public perceptions about problems and so forth. Is it politicians? Is it ICB leads? Is it industry? So targeting multiple groups of the list that I've just given, they can act synergistically to help you build influence around the topic that you're researching on. You've got to use the right medium to convey your message, and those media will be specific to the recipient. So if you're dealing with trying to influence public and public advocacy groups, then social media is really important. Getting on the radio, news media. But public health leads, ICB leads, politicians, policy briefs for these kind of people, arranging press conferences, press releases, and so on. And I'll come back to that in a second. Who's giving the message in terms of when you describe the results of your work is important. And I'm quite interested at the moment in how powerful children and adolescents are in terms of talking about research findings, because I'm in, as I'll describe in a second, a lot of the work that I do is in children and adolescents. And it's okay for us as elderly researchers to describe our results and how we want society to change. But using the participants in the research that you've done to articulate what they think are the changes that they want to see can be a particular way of getting your message across. So moving on, presenting your work directly to decision makers, I think that's a really important way of influencing policy. And so you can make these links with decision makers right from early on in your research, so that by the time you reach the conclusions and you're publishing the research, then you've already got those contacts and they're already interested in the results that you're going to have. So when you're presenting your results, rehearse your messages, rehearse the answers to the sorts of tricky questions that you might get. Overall, around impact, I think a theoretical framework can help. Next slide. So this is one that I found intuitively straightforward and easy to use. And Kingdon was, I think he published this about 2007, I think it was, but he came up with this policy windows framework. So if you're in, and this is how he structured it. What you're trying to do is open a policy window such that, and the imagery here is that that allows policy to change in some way. And he said, well, there are three streams that contribute to that. First of all, the problem stream. So society or the health service need to perceive the thing that you're talking about as a problem. If it's not perceived as a problem, then it won't be taken seriously. Secondly, there needs to be a policy stream. So what are the policies that are knocking around that you're trying to propose that might address a particular problem that's being discussed? And finally, there's the context of politics. And we know that politics changes very rapidly. For example, the government changed in the last months, and at a stroke, the politics of the health service changed completely in terms of the funding available and the commitment to make change. So Kingdon said that you have these different streams going on, and a window only opens when these policy problem and politics streams align. So you can apply this kind of simple model to whatever you're thinking about in terms of finding a way of making a change in policy. So as I said, when you are when you're doing your research, you can generate discussion about the particular topic that you're researching on, so that people perceive it as more of a hot topic to discuss. And the more that you do that, then by the time your research is published, the more they'll be receptive to your results and the potential for change. And conversely, politics, that's difficult to influence. Usually the people in power have got their particular political priorities set, but you can change that as well by the discussions that you have and the results that you generate. So I find this an intuitive framework to use. Next slide. Yeah, I think I've just discussed that. So yeah, next slide. So I'm just going to illustrate this with some work that we've done over the last 15 years, and it's around the London's low emission zones, the zones in plural, and the health impact. So about 15 years ago, we started an evaluation of London's first low emission zone. Many people probably don't remember this, but before the ultra low emission zone, London had a low emission zone that restricted particularly entry of polluting heavy goods vehicles within the Greater London Authority area. That started in 2008, went through to 2012, and we carried out a study in East London primary schools, in Tower Hamlets primarily, and some in Hackney. Next slide. So we recruited primary schools in there's you can see the spots there. Next slide. And we had a great time visiting the schools and measuring the children's lung capacity. And we visited these schools every year, and we measured the lung capacity of the children using spirometry. Next slide. So we did a lot of things, but we collected urine, saliva, and there were 4,000 children taking part, 115 visitors. It was a long and really enjoyable study. Next slide. And we carried out science outreach, engaging the children in science. Next slide. And it was all very interactive. Next slide. But the most important finding was quite unexpected. We didn't detect any particular improvement in health related to the introduction of London's first low emission zone. But what we did find was that the children's lung growth and the lung capacity were reduced in the areas where children were breathing the most polluted air. So the cleaner the air, the larger the lungs. The dirtier the air, the smaller the lungs. And those two eggs on the side are really designed to illustrate the volume of children's lungs that was lost in relation to the pollution exposures that these children were experiencing. So this was, London's polluted air was pretty polluted around the time of the research. Slightly better now. But next slide. So the results of this study were picked up very readily by the media, and so next slide. So essentially, we found that pollution was stunting the growth of children's lung capacity, and this was picked up by the BBC. It was picked up by public advocacy groups like Mums for Lungs, And there was a kind of sense of outrage that children's development should be so adversely affected. Next slide. And so one of the ways that we generated impact was to present our results directly to Sadiq Khan's team at the GLA. And so we arranged an appointment with the team, and really it couldn't have been a more direct way of engaging the public health team for the mayor in the results of the study. And we found that our research was sort of top of the list in terms of justifications for the expansion of the ULEZ, the implementation of the ultra low emission zone. So Sadiq Khan, it helped Sadiq Khan to frame the ultra low emission zone as a significant health problem. So that program of work spawned another study, which is the Children's Health in London and Luton cohort, and that study now has been running for 5 years. Next slide. And that study too got a lot of attention from the media, and the point that I want to make here is that right at the start, the launch of the study, we were already generating interest in the existence of the study and the possible results of the study in the future. So when we launched the study, it got media hits across the UK. It got media hits internationally. So it got a lot of publicity right from the start. Next slide. And it was, as I say, picked up by the BBC. Next slide. So we're at the stage now where we're starting to report the findings from this study. And one of the first papers we published was just a fairly minor sub-study from the work. But again, this was picked up by the BBC, and through that, multiple other media outlets. And one of the ways that was, particularly important in generating this interest was through press releases. So we worked really hard. There were multiple universities in this: Cambridge, Imperial, Queen Mary. So we worked really hard on the press release, making a very convincing information about the study. And making sure that this was, widely distributed at the time of the publication of the paper. So, this is a minor paper in a minor journal. Okay, we thought it was interesting, but we got massive coverage from it. So it illustrates that you need to be strategic, you need to be organised. And thinking ahead of the time when your paper comes out. Sometimes, papers, you don't know what day they're going to be published on, but, you need to be ready with all your information and press releases ready to go. And next slide. Okay, so this is my final slide. So just last thoughts and lessons. So plan your strategy from day one, embrace serendipity. I say that because we didn't expect the results around stunted lung growth in the first study, but we were delighted that they emerged from the study. You don't always get exciting results. So if you don't, well, that's okay, but you can learn for next time. Change can take a long time. So you're trying to make change. But if you think, for example, about smoking policy, smoking policy is something that has evolved over absolutely decades. So, it's not all going to happen just in one go. And then finally, with your work, when you make an impact, then it really does double your sense of achievement. So you really need to devote time, thought, energy, and funding towards that. Okay, I'll stop there.
Thanks so much, Chris. That was brilliant. And I think it helped us really understand what impact looks like and means in practice. And interestingly, I was just making a note for myself, and you articulated the very thing that, you know, it exemplifies that impact is a journey, or as we framed it here, it's a pathway. And it involves like working actively and strategically to engage stakeholders, to really kind of build in that sense of anticipation for the findings and what's to come. So it was very good.